Connecting up. Hi, everybody. Welcome to CrimCon. We're here on Wednesday in stream 1, and we have a really great panel here for you today. We're going to get started here in just a minute or two. I want to give folks just a little bit of time to join in, but not much. So we'll get started in just 1 or 2 minutes. While we're waiting on a couple of folks to join in, I'll remind everybody that each one of our panelists will have 10 minutes to present. We are going to be strict with time, so if you see someone get cut off, everybody knew that ahead of time. We also are taking questions in the Q&A box. So there's a button for attendees at the bottom of your screen for Q&A. If you click that and type a question in the box, we'll try to answer all of the questions that we can. Time constraints might keep us from being able to answer all questions, though. You won't be able to see those questions until we answer them. So don't be freaked out if you're not seeing any questions there, but do feel free to ask questions throughout the presentations, and we'll get to them at the end after everybody has presented. Our session here today is titled Delivering a Victim-Centered Response to Sexual Assault in Rural and Tribal Communities, Approaches and Considerations. That's all the preamble that I have, so we'll get started here with our first presenter. Please go ahead.
Thank you so much. Thank you everyone for joining us. My name is Joan Meunier-Sham, and I'm the director of the Massachusetts Sexual Assault Nurse Examiner Program, run out of the Massachusetts Department of Public Health. And the title of my presentation is Increasing Access for Sexual Assault Patients in Tribal and Rural Communities Through Telehealth. As I mentioned, we are a program of the Mass Department of Public Health. And in 2012, we're awarded a federal grant from the Department of Justice Office of Victims of Crime to pioneer the use of telehealth technology to export sexual assault nurse examiner expertise to communities that had little to no access to such expertise. And we worked together with the Department of Justice to identify 3 pilot populations, and that was military, rural, and tribal. And over a period of 6 years, provided real-time 365-day assistance to clinicians caring for sexual assault patients in these 6 hospitals. So 29 Palms, Robert E. Bush Naval Hospital, Camp Pendleton Naval Hospital, Sutter Lakeside Hospital in Northern California, which was a very rural critical access hospital, Hopi Healthcare Center in Arizona, and 2 Massachusetts hospitals that did not receive our current in-person SANE services. There was also a process evaluation involved in this, and they conducted interviews of clinicians both providing TeleSAFE support and receiving TeleSAFE support. We set up a national Tele-Nursing center at Newton-Wellesley Hospital, which is a small hospital outside of Boston, part of Partners Health, which is now called Brigham Mass General. And this is our center. They donated 3 office spaces to us that we put some proofing panel, dampening panels, and had privacy and confidentiality for patients. Unlike other telehealth visits, sexual assault visits and evidence collection processes can take 3 to 4 hours and sometimes longer. So it's really important to ensure that you have a secure environment for the patient. This is our technology, very simple in terms of monitor and camera. We have provided these carts, as you can see, so that the clinicians who are using the TeleSAFE support can roll them in and outside of rooms. This is obviously all HIPAA compliant, encrypted software that we use. And we use Secure Telehealth is the vendor that we use for our technology. So we developed a telenursing model. As I mentioned, we're providing that support 24/7, both audio and video conferencing. to the clinician. We have partnered with the advocacy centers in the community to bring in a rape crisis advocate, and that's who you see sitting in the chair. And then the TeleSAFE is working both with the patient and with the clinician who is providing care for the patient. We provide a 6-hour training, orientation training for the clinicians who will be receiving the TeleSAFE support at the hospital. And then a lot of ongoing education through the TeleSAFE portal for supporting our providers who are working with us in our partnership. We had, as I mentioned before, working with Hopi Healthcare Center, and really important to remember when you're working with tribal and rural communities especially is getting to know the community. We actually went out and visited with them and met with a lot of the people in their community. There's obviously, you know, a lot of well-founded mistrust sometimes of the government and other agencies. So we wanted this to be as much as their project as it is ours. And now that the federal project has ended, we are actually providing in-kind support to Hopi. You can see in the middle that they provide us with a beautiful bowl that included sage. And we cleanse the room before and after a patient because that is their practice of cleansing the room of bad spirits. So the woman on the far left-hand corner is Elise Sage, who is our TeleSAFE in Hopi. And it's really been important to plan from the beginning with them. We also work with an Indigenous Women's Resource Center as our national TA partner to try to, when we did solicitations for our pilot sites. And so really including the community in developing this project with us, and is what I would highly recommend for anyone who is looking to do similar work. Our patient impact, we saw 427 patients over the course of, since we have been using TeleSAFE. One of the things is that these hospitals had low volume. Initially, I think we thought we were going to see high volume hospitals, and in fact, they had very low volume hospitals, and that's why they needed assistance. What we didn't expect was then when we did solicitations for partners, most of our partners had SANE programs, but they were small SANE programs, they were new SANE programs, and the clinicians were not as comfortable with caring for patients. So our 4 federal sites had SANE nurses. The 2 sites in Massachusetts did not have SANE nurses, but the intervention worked really well with both. So of those 427 patients, we did exams with 266 of them. The other 161 were consultations for whatever reason. Either the patient wasn't eligible for evidence collection, or they were outside of the window, or they chose not to have it. We conducted over 140 trainings throughout this process, as well as I mentioned before, providing direct service. One of the things we really didn't know was how would patients accept this? They had just been traumatized. They were coming in to have this fairly long exam about a very intimate nature, and what would it be like now for them to be on a screen with somebody coming into the room. We were really pleasantly surprised. Overall, the patient acceptance rate was 86% across all sites. When we removed the military sites, it was actually a 97% acceptance rate. And part of that was sometimes in the military cases, it involved domestic violence where both partners may have been in the military. And so there seemed to be a little more concern around protection and privacy in those cases. So, but a very, very high acceptance rate on behalf of patients. And we didn't know how patients were going to feel or how the clinicians were going to explain this to the patients. But you can see this was a quote from one of the staff members who was receiving TeleSAFE support. She said, "It's always been an easy thing to do. Simply told the patient we have a partner who participates and who advises, and these are experts. And we have found we have better results in better exams. We let them know they can change their mind. At the end of the exam, they are usually delighted." So the clinicians did not feel that it was difficult for patients to accept TeleSAFE services. They were readily accepting them in most situations. We did, as I mentioned, a process evaluation, and so looked at the impact. And you can see from a -3 to a +3 scale on the impact of the experience of having telenursing or telesane experience, it was very high in terms of the clinicians increasing their confidence in providing an effective exam, their ability to provide the patient with the best care possible. The patient feeling comfortable was a little lower, but most people said that was just because of the nature of the exam, that these exams, while hopefully non-painful, are just uncomfortable and very intimate. And so they felt that that was more of a, because of that reason. So we call it the National Tele-Nursing Center, and it is still a program of the Department of Public Health. Our federal grant ended in 2018, December of 2018. Our governor has given us funding to continue to the program in Massachusetts. And as I mentioned, we are continuing to support Hopi Healthcare Center. We have expanded, or it will be expanding to a total of 11 sites. We're at 7 sites right now and adding 3 more sites in the next 2 months, all across Massachusetts, including our 2 island hospitals, Nantucket and Martha's Vineyard, and 3 critical access hospitals. So we'll have a total of 11 sites in Massachusetts, and then continuing to support Hopi. As you'll hear from Diane in a minute, we are also a partner with the International Association of Forensic Nursing, who has a technical assistance grant from OVC to replicate the model that we developed through the National Tele-Nursing Center in Alaska, Arkansas, South Dakota, and Texas. So we are on that tele-nursing technical assistance grant, and really thrilled to be part of that as well. So that is pretty much for my part, and I'm going to turn this over to Bryan, and I'd like to welcome you to reach out to me. This is my contact information, and also the link for our Tele-Nursing Center, as well as our statewide sexual assault nurse examiner program. Thank you so much for your time.
Great. Thanks, Joan. Very, very interesting. Next up, we have Bryan.
Bryan, you're muted.
There we go. I'm having some technical issues. It's too early in the morning for me. Good afternoon, everyone. My name is Bryan Fischer. I am the Sexual Assault Kit Initiative Training Coordinator here at the Montana Law Enforcement Academy. And what we're going to talk about a little bit today is we're going to talk about state, rural, tribal SAKI training program implementation. And so just starting out, we are currently funded by a grant from the Bureau of Justice Assistance. And with that grant, of course, the opinions that are expressed here are not really represent the official position or policies of the Justice Department. So just to kind of give you an idea, Montana is one of those particular states. We border 4 other states, Idaho, South Dakota, North Dakota, Wyoming, as well as 3 Canadian provinces. So we are a very large state where we have limited resources. And part of that is that our state is roughly 147,000 square miles. And within that, we have jurisdictions ranging from about 153 people in a county, about 1,300 square miles, to some that are just a little bit larger than that, ranging up to 3,000 or 4,000 square miles. So in Montana, we came up with a way to be able to address those issues from investigating sexual assault. My career has been spent 34 years, just retired from law enforcement, and I've been currently working on this program since about 2017. Back in 2015, the state of Montana went through and ended up getting a sexual assault initiative grant to do the backlog of tests. But part of the testing, or part of that grant process, was to be able to develop a training program that would be consistent with the current trends. And so that's where my job came into play. So back in 2017, our task force literally ended up getting together. It was a combination of professionals from all over the state, stakeholders that deal with sexual assault response. And we sat down in a room basically to come up with a plan on what we wanted to do, with input and associated, or I should say, specifically dealing with rural and tribal agencies, since that's primarily what we deal with here. So the first thing that we ended up doing is that we literally had to do a critical evaluation of our current training curriculum. So back in 2017, we did research for about the first 6 months, and we found that there were a lot of glaring discrepancies. So starting at that particular point, we knew that up to 2017, this was the material that was being taught, and we found that it was inadequate. It was too advanced for officers to understand. We were finding that the officers themselves had fear of investigating sexual assaults, and the scenario that they were going through to make sure that they could conduct an appropriate sexual assault investigation had an 85% failure rate. So it was at that particular time that we came up with an aha moment to basically say, hey, we've got to be able to give the officers the tools to be able to do the job. And it was pretty much self-evident. We were getting this information from field training officers, from administrators, from supervisors, and everybody came up with basically the same thing that said that they don't know what they don't know. So we also found out that in polling the officers that were coming through our basic law enforcement academy, which is where we're kind of unique. We have one central academy that all law enforcement officers in the state, anybody from a municipality, from a sheriff's office, including fish and game wardens, our troopers, and those that work on reservations have to come to the law enforcement academy. We knew that we could be able to make change, and that's exactly where we ended up making change. As you can see there, it said that even those officers that were in the field was less than 10% that had been exposed to a sexual assault investigation. So what we came up with is that we came up with an idea that we had to have a user-friendly curriculum that would be beneficial, was easy to comprehend. And so we decided that we needed to make sure what the officers needed to know. We found out that they were lacking in what a sexual assault investigation entailed. We knew that they did not understand elements of consent. They were having problems in processing criminal elements and the law and applying it appropriately. We found out that they did not understand the survivor trauma aspect of a sexual assault investigation. And then we also found that their communication skills were lacking. They could not say the words, they could not understand the intimacies of consensual behavior. And so we came up with an idea about how to be able to do that. Initially, it started at the Montana Law Enforcement Academy, and it was the starting point because at that time they were only utilizing about 4 hours. So we now have changed the input. We have developed a curriculum that is pretty much for all disciplines that are first responders, but the easiest place was to be able to start with basic law enforcement. We conducted a community survey with those rural agencies and tribal agencies to see what they were experiencing in their communities. And in those communities, we found that it just confirmed what we had already addressed at the basic level. So we were able to change that in an ongoing level. What ended up happening is that as we developed this curriculum, one of the things that we had devised was a reference guide for officers to follow. And that's how the training is referenced. So even if you don't have the training, the reference guide can give the tools necessary to an officer to be able to conduct an appropriate sexual assault investigation. I'll talk a little bit more about that in just a second, and it'll give you a way to be able to get a copy if you would like. The other thing is that we started to be able to test it and evaluate it as the officers left the field. And so what we were finding is that as they went to different agencies throughout the state, some of them being very rural, to some of them being a little bit larger, we found that our officers that went through literally a 16-hour training course at the basic level were doing better than those officers that were in the field. We have that by actually those agencies requesting for us to bring that particular training. And that's kind of what really led to it is that if we found that this is what was happening here in Montana, we could put that together in small rural agencies, and we could train the same thing. So we could train all of the officers, even though they had been through the law enforcement academy here in Montana. We could teach them on the same thing, which was all survivor-centered, trauma-informed training, and keeping that in mind. So when we started with small and rural tribal agencies in northeastern Montana. If you're familiar at all with some of the Wild West here, we have a place called the Bakken, which is in northeastern Montana. It was with the oil boom, and we saw a very large increase in sexual assault response, especially in some of those smaller communities. And so we targeted those particular agencies back in roughly 2019. We started giving those rural and tribal trainings. One of them was in the Valley County area, which bordered the Bakken, and we had a very big response from law enforcement agencies with the Fort Peck tribe. We found that in teaching the material that we had developed, it went over very well. It was stressed by administrators of those particular locations that the training that they were receiving that they did not have. And to give you an example, there are agencies in those extreme remote rural locations that would literally have to drive a survivor to a location about 150 miles away to actually get medical attention, or to another state to be able to receive a sexual assault exam. The majority of officers and administrators that work in those particular smaller counties are people that have never been in law enforcement before and have no idea how to be able to not alone conduct sexual assault investigations, but they had no idea from an administrative standpoint what they could do. And so that's where we found that the cross between what we were teaching at the basic level was going ahead, and we could develop that for a rural response. And it did cross across all disciplines. We are now moving on to a little bit where we're actually in the process of working on a 16-hour curriculum with a company out of South Carolina to be able to put this training together and to allow anybody to have access. And we're establishing a partnership to where now we're going to end up training the trainer, and that's going to work hand in hand, specifically with tribal agencies. The reason being is that we're going to take their input from what they're seeing specifically in their current tribes. And so we'll incorporate that into our training. I know I have only a few seconds left, but if you have any interest, this is the field guide that we did. This is used in the field. It gives the first responder insight to it, and it has a bunch of useful tools. There's a link that is there if you need to get it. There's my contact information. Feel free to reach out to me at any time, and I'll hand it off.
Fantastic. Thank you, Bryan. Really interesting. I want to remind folks again that if you'd like to ask a question, click the Q&A button and type a question into the box there. We've got a couple of questions already that we'll get to after our last speaker, but feel free to go ahead and ask those. We will move on to our next presenter.
Okay, well, my portion of this presentation is to talk about TeleSAFE programs in rural and tribal sexual assault response from the perspective of a TA provider, technical assistance provider. And so my name is Diane Daiber. I work for the International Association of Forensic Nurses, and part of my role as a forensic nursing specialist is that I am a technical assistance provider. Our organization, the International Association of Forensic Nurses, has been providing technical assistance for the last 15 years around the 2 national protocols on sexual assault medical forensic exams, as well as other national documents and protocols. So let me advance here. One second, there we go. I need to acknowledge that this presentation was developed through the funding of the Office for Victims of Crime, U.S. Department of Justice. So this is the findings, conclusions, recommendations, those are of the author and not necessarily those of the DOJ or any of the departments. So back in 2016, the U.S. Government Accountability Office reported that the number of trained sexual assault examiners does not meet the demand for the exams, especially in rural areas. So you can see the title of this grant is using telehealth to improve care, access, and quality of sexual assault forensic exams. And in addition to that, the overarching goal is also to include a support system for the victim, specifically some sort of victim advocacy. So OVC, in all their wisdom, realized that the demonstration sites for this project would benefit from a technical assistance provider. And that's where the International Association of Forensic Nurses comes in. To help these demonstration sites to develop a trauma-informed, patient-centered program, TeleSAFE program. So along with OVC, we work with our grant partners that you can see listed on here. And Joan, who just presented, of course, their team is one of the grant partners. So let me introduce you to the demonstration sites for this project. The first one is a Vera Health Center, and they're out of South Dakota, Sioux Falls, South Dakota. They have a very extensive telehealth presence already in multiple states. They have a variety of telehealth specialties, but this is a new one for them, and it's called eSane. So they actually have a brick and mortar building where the expert nurses will report to when there is a call from a remote site. So where the experts are, the expert sanes, it's called the hub site. Where the remote patient and the patient is, it's called the spoke site. So Vera plans to support under this project 43 spoke sites in 5 different states. The next one is Texas A&M, College of Nursing Forensic Healthcare program, and they are called TexTrack. They plan to support 4 sites in rural southern Texas, but I keep an eye on this Texas A&M program as their Attorney General has funded them to expand beyond this grant program. And also the fact that they're out of academia and not based in a hospital or healthcare setting. So then we have Tundra Women's Coalition, which is in Bethel, Alaska, which on a map like a big city, but there is no roads in and out of Bethel. And it's in the Delta area, which is about the size of Oregon. So Tundra Women's is a domestic violence sexual assault shelter, and they work very closely with the Yukon, I might destroy this word, Kuskokwim Health Corporation, or the YKHC. Who also delivers health to 58 rural communities in that southwestern Alaska. So southwestern Alaska is one of the highest rates of sexual assault in the nation, and the Alaskan Natives make up about 15% of the population, but they are the ones that experience about 43% of the reported felony sexual assaults. So right now, if there's a sexual assault in one of the rural villages, which is what they're going to be supporting, they're supporting 5 sub-regional clinics, which are small rural villages on southwestern Alaska. Right now, if there's a sexual assault there, that patient has to travel by plane or water into Bethel for an exam, and also the criminal justice. So the hope of this project is that they will bring not only the healthcare, but also the justice to the village, and hopefully increasing awareness and intolerance of the sexual violence. And last but not least, we have the UAMS, Arkansas Medical Science Center in Little Rock. These expert sanes will be working from around the state, providing guidance to spoke sites in 73 different facilities. That is their plan. So as TA providers, what have we started to learn? So we've got the first year under our belt, which is the planning phase. And I will tell anyone that's looking into TeleSAFE development that the planning phase cannot be skipped in any way. It is the most critical and most important. Getting to know your team, communicating between your teams, communicating with your spoke sites, and developing a needs assessment. It's an invaluable component of the planning phase. So we conducted a needs assessment with the hub sites. using SMART goals, which are specific, measurable, achievable, relevant, and time-bound. And it helped the TA provider to prioritize the technical assistance needs. So some of them were unique to the sites. Some of them have been kind of across the board. So for example, Joan's team and one of our members presented on Dr. Joanne Duffy's quality caring model. So that was across the board a technical assistance need. Additionally, we have conducted needs assessments with the spoke sites to help the hub identify what their needs are and that they can address those. So we initially had started working with the sites monthly separately, and now we're starting to combine the demonstration sites so that we can promote networking and cross-training through the different demonstration sites. And then sharing, OVC and IFN are sharing our lessons learned and innovative solutions with the larger field. The goal at the end of this project will be that IFN will come out with an online toolkit for the development of TeleSAFE projects. We have just started the implementation phase, and like everything else in the world, our pandemic has affected this project immensely. So things like site visits. So the TA providers had planned to do site visits to all the sites so that we could really understand their needs and their culture, and that none of that has been able to happen. And also the hub clinicians have not been able to make hub sites or site visits to the spoke sites to get to know the community and get to know those clinicians. Things like supply chain, so ordering their equipment so that the equipment can get delivered to the spoke sites, but not only once it's present and delivered, having the vendors having access to go into the hospitals has been a challenge because no extra persons have been allowed in due to the pandemic, including if they are seeing sexual assault patients. The advocates have not been allowed to actually physically enter and support the patient. So they've had to do some workarounds to figure out how to keep this project moving. There's definitely been training delays and just all sorts of things that have delayed this project. Each site is going to have a very robust evaluation process, but as TA providers, what we wanted to ensure was that there would be measures that were same measures across 4 demonstration sites. And similar to Joan's, we are going to be looking at the clinician's perspective, but something that is new is that we're going to be looking at the patient's perspective with the exact same questions across the 4 demonstration sites so that we can have a really robust amount of data to show the impact of TeleSAFE exams for the patients. In addition to that, we want to be looking at the advocate's perspective too. We hope that all sites will have launched at least, it says here, January of 2021. After meeting with some of them today, I'm going to say first quarter of 2021 due to some of the pandemic delays. So I feel like I ran through that. If I have a couple seconds, I might just talk about it just briefly because I skipped over it. Some of the things that we've done for technical assistance, so including that quality caring model webinar, we also brought in an amazing researcher to talk about how do you even work with the survivor of sexual assault and in developing your consent process for research, in developing your questions for research. So important things like that. In addition to, we'll review policies. We offer them templates of policies. And as you can imagine, the needs are variety across board. So here's my contact information. More than happy to talk to anyone, share any information that we have at this point in the development of the TeleSAFE process.
Thank you so much. This has been a series of really interesting and important panel or important work that you've been talking about. We do have a couple of questions. I think the one that I'm going to take first here So question for all presenters: how do your specific projects, initiatives, and trainings impact victim participation in case investigations or working with law enforcement as cases get processed? I don't know if someone wants to jump in on that. It looks like Bryan is champing at the bit.
So that's a great question. Our specific project dealt with survivor-centered trauma-informed investigations, and that was the biggest focus that we had. It dealt with literally providing them a script. So we actually explain the process to get the victim engaged with the process. Now, a lot of times the biggest issue that we had, and we've got some anecdotal evidence that dealt with that, because I've talked to a couple of victims of sexual assault, and the officers that have gone through the training and have followed the model. So it's literally a script, gives the officer the tools to be able to make sure that they're asking the right questions and getting the right responses, spending the time. We found that it was very beneficial, because we were talking to some of the victims of those particular crimes and found what those officers should not be doing. And that's leading us to a couple of other projects right now that are in the works, specifically for me.
Any of our other panelists want to comment on the extent to which your work is impacting victim participation in investigations? Oh, Joan, you're muted.
Just, to say that law enforcement may be involved at the scene, or they may come to the hospital to speak to the survivor if the patient or survivor would like to report to the police. So they are involved in the same way. They're usually not in the room during the exam, but they may be in the room during some of the TeleSAFE support. We are with the patient and the clinician for the entire exam. And we kind of have three parts. One is a pre-encounter. Before the patient is in the room, the clinicians will meet and talk about what they know about the patient and what they may expect. And the novice clinician may say to the TeleSAFE, this is how you can interrupt me. We call it gentle interruptions if you see me doing something that I should be doing differently. So we establish a team very quickly, and then the patient is in the room. And then after the patient leaves, we have what we call a post-encounter, where we'll package the evidence, we'll do chain of custody, review documentation, and then make sure that the clinician has an opportunity to debrief about their experience in caring for the patient. As you can imagine, these exams are, very emotionally charged at times. And, it's very difficult sometimes to be hearing, seeing somebody in their most vulnerable time. So what we're really happy about is most survivors leave feeling a lot better. And, the role of the SANE is really to help them on their journey to healing. And I think that happens. We've had survivors go up to the screen saying to the TeleSAFE, I'd like to give you a hug. I wish I could give you a hug, and thanking the TeleSAFE for being there. So it's been well received so far.
And Diane, you have a
I
comment?
really don't have too much to add because we're too early on in this project, but one of the things that is on our radar is to have the hub sites and the spoke clinicians get to know the law enforcement, their local law enforcement, and communicate with them and work with SARTs and help that, to develop SARTs in their communities.
And I'd like to remind folks that if you have a question, click the Q&A button and type your question. We've got one here for Bryan. Could you talk more about the use of full-time sexual assault training officers? Did you say those were administrators without law enforcement experience, and just sort of how that works?
Certainly. So the full-time sexual assault training officer, that is actually my position, was created specifically for me. And so I am dedicated to, and it's part of the grant, but I am dedicated to actually providing training throughout the state of Montana. So anybody who wants it, that's what we're going to end up doing. So we teach that, literally that 16-hour curriculum that we teach at the basic level. And I think this will go to the other question that Katie was asking about. We found through our research that Other states around the United States were teaching, what we teach at our basic level is what they're teaching at an advanced level in the majority of states. So what we found is that we have just tailored it to where we can just basically bring it into those particular communities because they are dealing with the same issues that the basic law enforcement officers are. So that's part of what was really beneficial for our particular development is what did we need to what do we need to teach even those that were in the outlying areas. And you say that there's not an example, but I can give you several of examples. We have communities where their agency is a hired sheriff. And this goes back to what Andrew's question was. We have individuals that are elected to sheriff's positions or appointed to positions who hold down other jobs. The current sheriff that was elected in Valley County, Montana, had been a write-in candidate because the undersheriff had been arrested for sexually assaulting a minor. So he had no law enforcement experience. In Montana, once you're elected sheriff, you don't have to have any law enforcement experience. So that's how we kind of addressed it. We had a lot of people that were hired in Montana. We can specifically go to work on the street. All you have to do is be sworn in and have no experience. So this is how we were going to be able to address it. The program that we developed went hand in hand with our reference guide. And even if you don't have training, it'll at least give you enough information to be able to conduct that investigation.
We have another question that's sort of along the same lines about whether there are supplemental tracks for officers heading to jurisdictions where they might need specialized skills.
Correct. We are currently working on that one right now. In fact, that's part of my job. So part of the, and this goes back to Andrew's question, the part of the training officer's position is to identify the gaps that we see. So some of those gaps are specifically supervisors and administrators that don't have procedures and policies in place. They don't have specialized investigators. So we're working on maybe in advance. We're putting together, and we have put together training all the disciplines, cross-training all the disciplines, and setting up rural sexual assault response teams so we can pool those resources. So that's kind of what we're working on. So that's in the next 3 years of this particular grant, that's what my particular job is. So a little bit of work to do.
We have time for one or two more questions. Click the Q&A button to ask. We'll give a couple of seconds here for folks to get their questions in. And in the meantime, I wonder if folks have any parting comments for those of us who are interested in this topic for us to take away from the panel here.
I think it's really important, as Bryan and Diane were saying, that the focus needs to be on a trauma-informed approach to patients. First and foremost, it's the care of the patient. And as nurses, we are there to focus on the health and well-being of the patient and connect them with law enforcement. One thing that I meant to say was, we've had a couple of cases where patients have been brought in saying, the police officer told me that I was going to meet this great nurse. So that connection with the community, as Diane was saying, that they know, that there's somebody with them in the hospital, but there also is going to be an expert brought in. So those connections, as you know, a warm handoff goes a long way. We haven't yet had any cases proceed to trial. We have had 2 cases that were CODIS hits. So the defendants pled, but we have not yet seen how this was going to play out yet in court. So we're waiting with bated breath to see how that will go.
Any other parting comments before we end the session?
I just have one. I just want everybody to know that I did type in the chat. If you have any questions whatsoever, that's part of what we're doing here. Feel free to reach out. I mean, we're all kind of fighting the same battle. I know that currently, right now, I'm working with between about 12 different states on updating that, and I'm more than happy to do whatever is necessary. It's extremely important, and I appreciate your time. Thank you for doing what you do.
I would like to thank our panelists for the work that they're doing. This is an incredibly important topic and often a difficult one to discuss. So I really appreciate the work that you're doing every day. I'd like to remind all of the attendees that the session is recorded, and we'll have the session posted up to YouTube as quickly as we can. Keep an eye on our YouTube channel. You can search for CrimCon and you'll find it. Or you can subscribe to our mailing list at crimcon.org, and you'll know when those come out. We anticipate doing that in the next couple of weeks. We're kind of busy running the actual show here at the moment, but we are going to get those up as quick as we can, so that folks who couldn't be here in person are able to see the sessions. For folks who are hanging out here for the next session, when we end this one, it'll kick you out, so you'll have to come back. Just to let you know. Thank you so much for the work that you're doing. We're gonna end this session, and if folks are interested in participating in the next session in this stream, just go back to crimcon.org/program and click on the stream again here in a few minutes. Thanks, everyone.
Thank you,
Thank you
everyone.
very
Thanks for
much.
your assistance.
Great to see everyone.
Thanks.